Morning and welcome to Medicine Grand Rounds. It's really my pleasure to introduce one of our own faculty who we were just discussing. I think this is her third major lecture she's given in 2 weeks throughout the country. Just an example of the excellence in speakers and faculty we have here at the University of Wisconsin in our department. Elizabeth Jacobs took her undergraduate degree with honors and distinction from Stanford before attending UCSF for her medical school, and then undertook residency training at the Brigham and Women's Hospital in Boston. She followed that with 2 years at the University of Chicago, where she took a master's in public policy as a Robert Wood John clinical scholar, and then joined the faculty first as an instructor, then assistant professor, and then associate professor at Rush Medical School. She also held a joint appointment in preventive medicine and was co-director of the Center of Urban Health at Rush University Medical Center. In 2010, we were very fortunate to recruit her to our faculty as associate professor with tenure and associate vice chair for health services research in the department. She is currently full professor of medicine and holds a joint executive appointment in the Department of Emergency Medicine. Dr. Jacobs has published broadly. I counted 91 publications in high-impact journals, including Cancer, the Journal of General Internal Medicine, the American Journal of Public Health, the Annals, the Archives, JAMA, and in 2013, 2 articles in JAMA Internal Medicine. She's also authored 6 chapters and monographs. Throughout this time, she's been very well supported in terms of grants. Currently, she holds grants from PCORI, from the Carbone Cancer Center, the American Cancer Society. She's co-investigator on another 4 NIH grants, and she's held a number of major awards in the past, including from the NIH, the Russell Sage Foundation, Robert Wood Johnson, and the National Cancer Institute. She's an avid teacher and mentor and really a role model for so many individuals. Her classroom teaching has even extended to Addis Ababa, the Black Lion Hospital in Ethiopia in 2012 and 2013, lecturing about clinical and translational research. She's been PhD committee member for several individuals, and I counted 37 various fellows, faculty, residents, medical students, grad students, and undergrads that she's been mentoring over the last 5 years. Dr. Jacobs has also been a very generous citizen nationally and regionally. She's been the president of the Midwest Society for General Internal Medicine, and she's been involved at the national level with the Society of General Internal Medicine, Kaiser Permanente, AHRQ, NIH, the Sage Foundation, Aetna, the Joint Commission, the American Cancer Society, and the National Quality Forum. And in 2013, she was named a member of PCORI's Health Disparities Advisory Panel, and I know they're lucky to have her on that body. She serves as a deputy editor and has been on the editorial board for the Journal of General Internal Medicine as well. Along the way, she's earned a number of honors, including AOA. Here in Wisconsin, she was named the Addis Costello Award winner from the Wisconsin chapter of the American College of Physicians, and the Midwest Society of General Internal Medicine recently awarded her for leadership in 2015. Dr. Jacobs is an advocate for all of us to improve the care that we provide to the underserved. She serves as a role model and has established herself nationally, as I mentioned. We're really fortunate that in all her speaking engagements, we're able to have her here on our faculty. And today she's going to provide grand rounds entitled Providing Better Care to Hmong and Spanish-Speaking Adults, Lessons Learned from Our Patients. Please join me in welcoming Dr. Jacobs.
Thank you. Is my mic on? Can you hear me? Excellent. Wow, I didn't know I did all that. Actually, thank you very much for having me here today. One of the things I like to say is when I give talks and people introduce me is that, you know, it's there are a lot of things on my CV, but they're all in honor of actually improving care for our patients, particularly in primary care, because I'm a primary care physician. And you'll see that's the theme of this talk. And I'm going to talk about the remarkable people who've worked with me who I all consider mentees on this grant at the end, and they're also part of that mission. So I'm delighted to have an opportunity to talk about that. I also want to thank Ruth O'Regan, who switched days with me so I could give one of those other talks. So I appreciate that. She gave a talk last Friday, so I could be in Utah giving a talk there. So, what to expect this morning? We're going to talk about information about who are our limited English proficient patients in the UW system. What I mean by limited English proficient are people who say that they cannot speak English well or at all. Those are people who you would imagine, and we know, have trouble communicating in healthcare. I'm going to talk about our study and some of the results, and then I'm going to talk about things that we can do as providers within our system and individually to actually improve the care for these patients. So I think it might be surprising for many of you to know that we actually have a fairly substantial limited English proficient population in our system. If you look at our system as a whole, it doesn't necessarily look very diverse, but the fact that we take care of so many patients, there is a substantial number of people, if maybe not proportion, that actually are diverse and actually don't speak English well. So in 2014, this is from actually an R01 that's going to be under review in 2 weeks. We had 36,000 patients, encounters with LEP patients, for which an interpreter assisted in our communication. One of the things that's fabulous about our system here, and I have to thank Shiva Bidar-Siala for this, is that we have excellent data on who our limited English proficient patients are in our electronic health record. That's actually extremely rare. I've been working on this topic actually my entire career, and it's very hard to find data that's this good. So I feel very confident in these numbers. And the vast majority, you won't be surprised to know, are Spanish-speaking, 60%, and 10% are Hmong-speaking, and then the other patients tend to be from a variety of different languages. We know nationally, but also in our system, that they experience health disparities. I want to thank Jennifer Weiss and Heather Johnson for some of this work. Jen showed that in one of her studies that the odds of receipt of colorectal cancer is half if you don't speak English compared to those who speak English in our system, and that was highly statistically significant, and that the hazard ratio for being diagnosed with hypertension if you have two or more documented elevated blood pressures over a certain period of time was also about half if you don't speak English well. So it shows that these patients are not getting the same quality of care that we're providing to our English-speaking patients. And that led us to be motivated to actually do the work that we were generously funded by the Cancer Center to do. But before I get to that point, I want to ask you, why do you think that might be? Why do you think patients who don't speak English in our system might experience disparities?
It's complex. I think it's not just the language. Language is one, but there are other social determinants of health that goes along with not speaking English.
I think everyone can hear Nizar, but I'm going to repeat that. Thank you, Nizar. It's complex. It could be language, but there are a host of other things, socioeconomic and cultural factors, that also actually contribute to disparities that these patients might experience. That's exactly right. And that was our question. Is it language barriers or is it something else? And we wanted to find out more about that. So our objective was to examine factors that contribute to disparities and receipt of preventive cancer screening among LEP, Hmong, and Spanish-speaking patients in our system. Now, we asked specifically about cancer screening. That's actually part of what we asked about. But we actually asked them generally about their care here, as well as some other questions about their experience getting care outside, inside, in the community. So even though I'm going to give you some specific examples around cancer care, a lot of what we've learned in our study is actually really generalizable to the patients that we take care of who are Spanish and Hmong speaking. So we conducted a qualitative interview study. I put this slide in here because I wanted to stop for a moment and talk about what qualitative research is, because I'm not sure anyone's had a presentation here on a qualitative research study before. So sometimes qualitative research is really thought of as sort of a soft science because we're not measuring something in an extremely controlled environment, or we're not designing a survey that goes out and asks very specific questions and there's a certain limited of responses that people can give. But really, it's a way in which you elicit information from people in a very open-ended way, either in conversation with them in a one-on-one interview or actually in a focus group. It actually is very rigorous in its own discipline. We're going to talk a little bit about that. But the reason why you do a qualitative study, is when you don't really understand the phenomenon that you're asking about. It's particularly good if you're actually, I do a lot of this because I do obviously a lot of cross-cultural work. And in my experience, in my life experience, I don't really know what it's like to be Hmong and limited English speaking in our system. And I could devise some question because I think in my head what it is, but it's coming from my perspective. It's not from the patient's perspective. So these kinds of studies are really good to ask people what is their experience, and you can use that information then to design a quantitative study or a survey study where, and in fact that's part of our plan to do this based on this study. But it's really to get the perspective of the individuals that you're interested in understanding what their experience is. It can be hypothesis generating. That's usually what I use it for. But it can also be to identify issues that you're not capturing. A lot of times if you're doing something over and over again and it's not working, it's good to go to the people you're doing it over and over again with and say, why is this not working? That's another way you might want to use a qualitative study. So we're going to talk about the study today. So our participants were adult male and female patients who received primary care within the UW system in the last year, were eligible for preventive cancer screening. So that was men over 50 and women over 21. They had to have no previous diagnosis of cancer. They identified as being limited in English proficient, and they spoke Hmong or Spanish as their primary their primary language. We also interviewed primary care providers. Some of you might have been in the study, but I'm not going to say who you are because we're going to maintain confidentiality. And I thank you for your participation. So we conducted semi-structured interviews with these individuals in our study. What a semi-structured interview is when you meet with a person one-on-one and you have a set of questions you ask that are very open-ended. So for our patients, it would be, what is your experience like getting care within our system? And if that's too broad, then you have to bring it down and ask specific probes. And so we ask these open-ended questions about, this is for both providers and patients, care experiences in general, experiences receiving care for patients and delivering preventive care within our system for providers. Do they have recommendations for us for how to improve on delivering care to patients who don't speak English well? And then if no one brought them up, we probed on language-related barriers because that was a primary interest in our study. We conducted interviews in Hmong and Spanish by bilingual staff with the patients or in English with the providers. And the interviews were audio recorded, transcribed, and then we translated them into English. Some people would say you should really code and analyze data in the primary language, but this allowed us to have a broader team of people actually coding and learning from what was being said. As you'll see, there were some issues around translation, particularly in Hmong, because I don't know how many of you know this, but Hmong was not traditionally a written language. And actually, there's a phonetic written language that's kind of been imposed on the Hmong, so it can be written, but it's not a part of their tradition. It's an oral tradition. We then conducted this qualitative analysis, which is systematic and rigorous. Sometimes people are worried about that because they're worried about the objectivity that people might bring into the analysis. But we did something called conventional content analysis. Some of you who are familiar with qualitative research might call it something different. One of the things I found in qualitative research is people have a lot of different terms that are kind of referring to the same thing. So I like to name it and then define what we did so it's clear what we did. So basically what you do is it's an iterative process. You go through all the transcripts and you come up with codes. So let's say language comes up a lot. You're going to come up with a code on language barrier. You define it. You go through all the transcripts that way, different individuals looking at them and coming up with different codes. You come together and define a final code list based on all that generation of information, and then you use that final code book to code all the transcripts. To maintain more subjectivity, or to make it more objective and less subjective, you have 2 coders per transcript look at the code, and then the code the transcripts, then they come together and they talk and they say, why did you code this way, why did you code that way? And if there's a difference between the two, it's resolved by consensus, and sometimes you bring it to the team if there's an issue. So that way you're very systematic in the way you apply these codes. One of the things I want to point out about this is that we are not taking an a priori formula or idea about what the data is going to show us. We're going to the data and we're saying, what is it telling us? This is a hallmark of qualitative data. And we used in vivo qualitative software to catalog and code the data. It doesn't analyze it. We do the analysis as individuals. It doesn't analyze it like a typical data analytics software would do that you're probably familiar with. We conducted face-to-face interviews with 11 Hmong-speaking UW patients, 10 Spanish-speaking UW patients, and 8 primary care physicians. Here's some of the demographics. I have a pointer, do I? Here are some demographics. So one of the things I want to point out, which I think gets to the point that Nizar talked about earlier, is how socioeconomic and other issues might impact our patients. As you can see, the Hmong and the Spanish-speaking patients are very different in certain ways. So the age range was about the same, but as you can see, the Hmong patients are much more likely to be insured, particularly by Medicaid and Medicare, and that has to do with historical reasons that they were repatriated here because of their role in the Vietnam War, and so they were brought over by the United States and helped to bring them away from persecution. In addition, but you can see the Spanish-speaking patients are much likely to be not be insured or to use Access Community Health Center as their. And then if you look at the education, 64% of our Hmong patients, it's small at 7, but said that they had no education, which is really remarkable. I think that's really important for us to think about when we communicate with our patients if they're Hmong, especially the older Hmong. They may have not had no education, and the way we're going to talk to them is really going to depend. We should really be thoughtful about that as we're communicating with them about their literacy level. And then the Spanish-speaking patients were much more educated. As you can see, they had a range of visits. Thank you, Clint. Okay, so now I'm going to talk about what are some of the issues that patients brought up. So here are the patient-identified facilitators to getting care within our system. So I want to point out, I love to point this out because people sometimes feel so overwhelmed by how to take care of patients who are different than they are. They face these cultural barriers. That we can play a huge role in what our patients do. They talked about if their patient made a recommendation for cancer screening, that's been shown in English-speaking populations too, if we showed caring and respect, so really interpersonal competence is key. They also talked about their experience with cancer among friends and family. I'm going to give you a representative quote later, but if people actually had a positive experience, that influenced their likelihood of getting screened or engaging in care. And then for the Hmong culture, which is a very collectivist culture and not less than an individual culture like we have in our society, family support was also really important in motivating them. They also identified a number of barriers. So distrust of the healthcare system. So if they had previous negative experiences in healthcare, if they experienced poor quality interpretation, and then this is a huge issue, is lack of knowledge of cancer and what prevention is and what I can do. So one of the things we asked, we did a little quantitative survey after our qualitative work where we asked a number of things, demographics, that you saw that. But we also asked our Hmong patients, and I don't know, is Mai Chu in the audience? Oh, Mai Chu's there, thank you. So Mai Chu is a doctoral student who's Hmong in nursing here. And we talked about the fact that in her community, she wasn't sure that actually people understood cancer to be something that they saw it as a Western medical thing. And so we asked this question, thanks to Mai Chu. We said, did you know about cancer before you came to the United States? And then we'd ask them, what do you think it is? And people said, no, I didn't know, and I think it's an invention of American doctors, of like Western medical care, because it's not a part of their cultural concept. And there actually is no word for cancer in Hmong, in the Hmong language, and that they use these two phonemes, cancer, I hope I'm saying that right, to actually talk about it. And then the interpreters have to describe what it is. They have to give a description because there's no known definition or concept in their culture. So that is an issue, and what you'll see later, a lot of physicians And I know I have my own experiences with having frustration around that. There are financial factors. That's more for, you can imagine, the Spanish-speaking patients because they're less insured. And then there are some differences in cultural belief, embarrassment and machismo, and spirit illness that might influence their likelihood of getting care. So I'm going to give you quotes that come directly from the interviews that we conducted. So patient facilitators. This Spanish-speaking male said, this is a facilitator, if the doctor also made me feel welcome, it wouldn't matter if I work a lot, I'd make the effort to find someone that can change a work day with me or whatever. I'd go to the clinic. That's showing the power of our relationship. This is a Hmong-speaking female talking about the family influence and community experience. Yeah, because most of the time I've gone first, so I know before. She's saying I'm going to the doctor first, so I have experience that I share. They're the people after, so they don't know, and they ask me, what did he do? Okay, so then you have to not scare them. You know that the first time you are scared of them, too, you have to say, oh, before I was scared like you guys, too. But after they finished it, I'm not scared anymore. After they do it and you come back and say, yeah, it's okay, too, checking up like that is good for you. So this also shows how what we do as individual as physicians not only impacts our individual patients, but can really influence what's happening in the community because it goes back out to the community. Here are some quotes about the patient barriers. Previous negative experiences. There was one time, this is a Hmong-speaking female, there was one time I went, there was a doctor that actually scraped a small part of it for a checkup. She's talking about her cervix. I changed my clothes and I saw, it's some blood. When the doctor returned, I said, if you were going to check this, why didn't you tell me you were going to do this? You said you were going to check me like anyone who was pregnant. You were going to check the cervix. Only you scraped my tissue and there's a cut. Why is it bleeding? So I really like this quote, and I really like this work I do because my patients these people who work, give us this information, remind me that sometimes we go in there as physicians and we forget to tell them what's going to happen. And then something happens they don't expect and they think there's something wrong. So this is something normal. Like, I think about this now all the time when I do a pap smear because often people bleed after a pap smear. And I remember this woman's quote and I tell them, you might going to have some bleeding after this, but that doesn't mean I did anything different than I said I was going to do. And it's just a normal thing and it's going to go away. So actually really helping patients understand what they're going to experience. This is true whether you're Hmong speaking or Spanish speaking or English speaking. I think we should do this with all our patients, but it can really particularly negatively impact these patients who come in with some level of a higher level of fear and distrust than maybe some of our other patients. Here's someone's talking about poor interpretation. We can talk about this a little bit later if there are questions about this. This is a Hmong-speaking male. Or there are some that come to translate you and they don't speak everything you say to them, but there are some that are mean and they refuse to translate your word to them. So one of the things that we found in our study is that the Hmong patients in our study had a worse experience with interpreters than the Spanish-speaking interpreters. And we actually talked to Shiva about this. And it was something that she, Bidar Shalif, who's the head of interpreter service here, and it's something she actually identified even before we did our study. And it turns out that there was a huge turnover in the Hmong interpreters right after we did our study for some of the issues that our patients actually recognized. But those interpreters can also have a huge influence. And so if you notice something going wrong with the interpretation, there's ways to talk about that or address it. Again, we can have that a discussion after I end my talk if that's something that's of interest to you. Lack of knowledge. This is a Hmong speaking male. Cancer. Cancer is when we live in our country. There's not much. When we came to this country and hear about it, we don't really know what it is. Prevention. This is a Hmong speaking male, although this was also true in the Spanish as well. The Hmong does not have any education, so the Hmong think that they can wait to see if it is. Once they know, then they will go get checked. So that's why they wait too long, and before you know it, it's already worse and bigger. Financial factors. A lot of people, this is Spanish-speaking female, a lot of people don't have medical insurance. A lot of people are young and can't join a women's health program. She's talking about men. Unfortunately, it's harder to get insurance in this country if you're a poor man than if you're a poor woman. Because I think once you turn 60 or 65, I'm not sure exactly. And a lot of people don't have medical insurance. So that has a lot to do with the fact that a lot of people don't get it done, the cost. Cultural factors, machismo. We are very manly, this is Spanish-speaking male, and we don't allow anyone, like they do that rectal touch, don't do that to us. That's what I mean with machismo. A point I want to make here is that we could not even, it was so hard to get Spanish-speaking men in our study. When they heard what we were asking about, we weren't going to do a colorectal exam, we weren't going to do colorectal screening, but there's such a taboo around this in their culture. We learned from the women who helped us bring the men into our study. This is one of our tips for you, that there's such a taboo around this area of the body for men, and the idea that could make you turn homosexual or something like that, or how you might feel during it, that it was very hard to get men to come into us. So this might be, an idea for this might be, we think about other ways to actually test for colorectal cancer, like fecal occult blood testing, or something like that doesn't actually involve this might be one way to engage this population more. Again, something we wouldn't have known if we didn't actually do the study in the way that we did it. And then for Hmong, there's this concept called spirit illness, and I'm not going to say this word because my two taught me how to say it and I forgot. But it actually means spirit illness, that your strength is really getting weak. Like right now, you might still be working, but you are tired, and when you walk slowly. This is when your spirit is not home, and it's searching for another mom and dad. So then they will do the procedure to call the soul back to the original body. So this is a Hmong-speaking male. So he's talking about how you get care in your community by a Hmong provider to actually call the spirit back. And this is an issue that is important in this population to think about. When do they go to seek Western medical care versus when do they go to seek traditional care in their system? And it turns out that we've actually done some additional analysis that shows they actually will go to both, and there's different ways that they go to both. It has to do with how much pain they have, how acute they think the problem is. And then if it doesn't work in the spirit illness world, if their traditional healer isn't working, they will come to the Western medical doctor. And if the Western medical doctor isn't working, they'll go to their traditional healer. So one tip for us to think about is that when we see patients who are Hmong, we might give them an idea of this isn't going to work right away. You're not going to feel better right away. I'm going to see you back. Let's talk about it if it's not working, because there's different things we do to maybe keep them engaged with us instead of just leaving the Western medical world and going out to the traditional world if it's something that we think we can help them with. So what about physicians? What did you say? These are the facilitators people talked about, the electronic medical record reminders, reminding them to provide preventive cancer care, and then language-appropriate education materials. Although I want to say more than that, it's not just language appropriate, it's really culturally appropriate as well, is what people actually also highlighted. And then what are some of the barriers? And some of the patients brought this up in the quotes you saw earlier. They have competing demands, right? You're poor, you don't get sick leave. How are you going to leave to get a mammogram? Super hard. Time constraints, very similar. And then ability to understand and address cultural differences. There was a lot of frustration expressed around this, and that's part of why I'm giving this talk today, to try to help with some of those things. So here are some quotes. EMR reminders: when they do their routine physicals, or if a flag comes up, and my regular medical assistant is good about that. She's due for a mammogram, she's due for a Tdap, Language-appropriate materials. So I really appreciate when there are foreign language handouts and things. I don't actually use them as much as I should. I haven't delved into what we have to know, say, in different Chinese dialects for things like colorectal cancer screening. We have stuff that's really good in Spanish, but the other things we actually don't have very good. That's, I think, a lesson we learned from this study. Here are some barriers. Patients' competing demands. Their struggle is with day-to-day life and where they're going to stay that night and where their food is going to come from. So for them to realize you have 1 in 8 chance of developing breast cancer during their lifetime, we should screen for it because you're at high risk. That's just not on their radar screen, I don't think. So that's just a prioritizing of their life concerns. Time constraints. I also think there's probably a little bit more of a delay sometimes in me getting to the screening topic. Like if there's someone who has a language barrier, for instance, sometimes I'll just break the topics up over a period of visits because it's just too much to fit into a normal visit length if you're also working with an interpreter. Ability to understand and address cultural differences. I have this most in mind when it comes to my Hmong patients. In general, their beliefs about health or their beliefs about health being tied to spiritual issues. This person really understood their Hmong patients, by the way. And therefore, I'm not sick. Why are you doing something to me right now? Or I don't feel like I have a great way of addressing spiritual issues. So therefore, I feel like, boy, I don't think I've done a very good job of dealing with, though I do the best I can. I'm dealing with them from a very Western point of view. So this is, I just put this up here. We talked about these negative experiences that patients have and their positive experience. And one of the things we also saw in our data, even though we actually didn't specifically ask about it, was that it really does influence their future health-seeking behaviors. It can either, if they have a lot of positive experiences, they'll continue the use of the care that we provide. But if they have a lot of negative experiences, they're going to go back out into their alternative treatment and into their community. And the other thing I want to reiterate is that when this happens, people in their community are finding out about it too. And then their community is not doing this either. So when we're taking care of patients and we have this individual interaction with them, we have to think about how we're influencing what's happening outside our office too, because that's also really powerful, particularly in the Hmong population. So what are the limitations of our study? It was a single site. We only looked at 2 languages, so we don't actually really know what it was like for some of our other limited English-speaking patients. And we realized at the end when we analyzing this data, particularly when there was a lot of comments about the interpreters, that we didn't ask the interpreters about their perspective. And we actually talked to Shiva about actually doing some interviews with the interpreters. That hasn't happened yet, but it's something that we would like to do. She's all on board. It's just we haven't gotten around to it because I'm, as you heard, I have a lot of grants and might choose a doctoral student. So we've had a lot of things. But it has inspired some interventions that we're really interested in working in. So part of the reason we talked to Shiva is we think it's really important for interpreters to get feedback on what their patients' experiences are like. I don't know how often that's happening, and so we've been working with her on that. As you saw, it's really important to interpret the community. One of the things that was really powerful for me is that one of the patients, one of the participants who's Spanish-speaking and heard about the study called me and said, I'm calling you because you have to come out into my community. You know, he got it off the IRB consent, my name. If you have any problems, call Dr. Jacobs. He's like, I'm calling Dr. Jacobs because I want Dr. Jacobs to come out to my community. People will be motivated to take care of their preventive health if we get out there and tell them what it is and what we can do. But my community just doesn't know. So that's something that we're working on as well. And then I think this is part of what I'm doing today, is helping you understand your patients and their experience, and then to also give you some tips on what you can do to actually overcome some of these issues. The other outcomes I just want to say, because this is part of mission, okay, the academic part, we have 9 papers, 2 have been published, 3 are out for review, 4 in preparation, just from this small pilot. Just want to point out the number of students that got to experience research and really understand the experience of patients. So a postdoctoral student, doctoral student, MPH student, Rush student, pharmacy student, medical student, 2 undergraduates, and 2 of my Hmong mentees actually been motivated to go to medical school, actually based on the experience. So I consider that part of success of this project as well, because I think the other thing that we need to do is not only think about our own individual care, but how do we train the next generations of physicians to take care of a diverse set of populations. And the more physicians and other healthcare providers we have out there, nurses, PA students, one of these students is going to go on to be a PA student as well, is really to help diversify and get different ideas out there and people who understand different cultural concepts into healthcare, and that will help us do a better job as well. Okay, so the good news is, this guy says, thanks, doctor, I really feel like you understand me. He's naked and his jacket on backwards. Is that we can do something. I hope you saw that in some of the quotes that I talked about, is that and this is what I tell people all the time. Sometimes people are like, oh, cultural differences, language barriers, I don't know how to do it. Yes, you do. Be a good doctor. That's what patients want. What is a good doctor? Someone who listens to them, someone who respects them, someone who cares about them, who expresses caring about them, who says, man, you know what? I'm really not, this is so important that you get this set of care. I'm really worried that I'm not explaining it to you well enough. Can you help me understand why you don't want to get care? Ask them respectfully. So that's the good news. We can make a difference. And you don't have to do anything that different than you're already doing. So some recommendations are to remember to recommend to your patients the kind of care that you want them to get, particularly cancer care. Demonstrate respect, caring, and curiosity. That's really important. I like to say, I actually just gave a talk on Wednesday where I talked about be respectfully curious about what patients' experiences are. So you can ask them, sometimes people sometimes my patients have had really bad experiences before, and they're saying no to the kind of care that I'm offering because they've had really bad experiences before. Has that happened to you? Is that something that's going on? Can we talk about that? So just very respectfully ask them about their experience. Patients love it when you want to know their bad experiences. And then I always say, when they bring up their bad experience, I say, thank you for telling me that, because I don't want to be that doctor. I want to be a very different doctor. I want to understand what you experienced, and I want to be different. So that's inquiring about patients' previous experiences. I just got that. And then be sensitive and aware of patients' cultural belief when discussing preventive screening options. So I think what was brought up is that in these conversations is that people might have different beliefs or not really understand what the concept of prevention is. So thinking about how to talk about it differently. The other thing that I would say that I didn't add on here, I was thinking about it this morning, is that, and I thought it was on here and I'm sorry, which is that you should actually enlist the family members that come with the patients, particularly in the Hmong culture, which is a very collectivist culture. And Mai Chu's doing this really interesting work where she's looking at English-speaking family members coming in with their elders, their parents who don't speak the language, and how you can, and then Linda Park, who's here, just put in an F30, I think Linda's here, actually to look at how can you treat the dyad in these collectivist cultures of both the parent and the child. How can you get the child to actually work to be part of the healthcare team? Because a lot of times in these cultures, that's exactly the way it works. So thinking about how to get information about what might be going on with a patient from the family member or trusted person who's there, but also enlist them in helping you with the care. If you can do it sensitively and obviously in a HIPAA compliant way, if they're there. I just want to say thank you. These are all the great students who work with me, the Carbone Comprehensive Cancer Center, and then Hector and Perk, who supported the space and IT needs we needed. And this is just some pictures of my team. This is the Hmong team. They presented at this awesome Asian American conference. And I'm going to end there. I like to end early because I often find a lot of people have a lot of questions, and even questions about, like, I'm in this difficult situation, what would you do? So I'd like to open it up for questions at this point.
Thank you very much, Liz. I'll ask you to call on the audience and please repeat their questions for the recording.
Yep, thank you. Molly.
That was great, Liz.
Thank you.
There's two things. One, if you need support for your Hmong graduate student, I've been opening on my R25 and we include Hmong as underrepresented minorities. So that's one.
Okay, excellent.
Two,
Mai Chu, did you hear that?
when I'm trying to explain the value of qualitative research to people, I say, if you had somebody who saw a house burn down, would you talk to that person or would you take a random sample of people on the block? That was great.
That's great. So Molly said one of the analogies that she uses to talk about the value of qualitative research is, he says, if you saw a house burn down, would you talk to the person who was in the house or take a random sample of people on the block? It's true. Other questions? Yeah.
Nice job, Liz.
Thank you.
I'm always puzzled when I have a Hmong family and the interpreter, the relationship. If I have a patient come in and just the daughter comes, usually our organization doesn't like that. They want an official interpreter. But the daughter or son almost tells me equal in the amount of time spent in them talking in their language and mine of what the patient said.
Okay, so to repeat the question, I hope I can get all this, Anne, is that when a family member comes in with a Hmong older patient, that oftentimes the interpreting seems more efficient, and the Hmong child actually seems to give more information than if there's actually a Hmong interpreter in the room. And there's often this back and forth between the Hmong and the interpreter, and if it's a hospital interpreter, and is that some cultural maybe factor that is playing out there, that they're trying to show respect or develop a relationship. So what I would say to that is that actually that's poor interpretation, and that can happen in any language where the interpreter will actually have a conversation with the patient and then not tell you what's going on. I don't know if particularly with the Hmong that's actually a cultural factor. Maichu, do you want to weigh in on that? Do you have any thoughts on that?
Well, there's a couple of factors, I think.
Oh, thank you.
Oh, thanks.
This is Maichu Lor. She's RN, PhD.
In regards to your question, I think there are a couple of things. And Liz and us, we just actually got a paper published looking at, in our paper that was published with looking at interpreter quality, some of the Hmong patients did share that there are conversations where they have with the interpreters, and the interpreter actually don't pass that information. As one of the quote that Liz have shown about, patients feeling like what they've been said, what they want to say to the physician is not being said because they're not getting the treatment they want, or not knowing how to take care or take their medications when they go home. So I don't know if it's so much of a respectful, but maybe it's more of I think there needs to be more training with interpreter versus a culture factor.
One other thing I want to add to that, Maichu, thank you, is that one of the things that we found is that one of our patients, our Hmong patients, told us that the interpreters were so interested in pleasing the doctor, sometimes they weren't happy with what the patient was saying because they thought, one of the patients was upset, and the patient was like, "You're not communicating to the doctor that I'm upset." But the Hmong was like, the Hmong interpreter was like, "I don't want to communicate to the doctor you're upset," and that's actually someone who's not really not either well trained or is not following their training because they're really supposed to be a conduit, even of emotion, not actually just words. And so I think that has to do with the training. I agree that it's less an issue, and it could have something to do with culture, but really about how the Hmong interpreters see themselves in the role with the physician. And one of the things that I like to do is if that's happening. So a lot of times, people will tell me these stories like, "Oh yeah, the patient said all of this, and they had a conversation, and the patient says no." I said, well, just go back to the interpreter and say, "Hey, you know what? So much of what happens in an encounter are so much of what we learn about patients, right, is in their asides or kind of they're going on, and it's clues, it's medical information, and so a lot of times, and so we need to ask them. It's good to ask the interpreter, like, you know what, I know you might be thinking that it's just better to summarize, but I really need to know everything that happened. Can you tell me what you just had a conversation about so you can stop them and actually have them do what you want them to do?" And a good interpreter will say, "Dr. Schmidt, I'm now going to tell the patient that I have to leave at 5:45 or whatever, so I may not be here for the whole encounter." Then they go to the patient and they say it in Hmong, and then let's say the patient says, "Well, that's okay," and then they say to the patient, "Okay, I'm going to now tell Dr. Schmidt in English." So a good interpreter is making sure that you know everything that's going on, and that has to do with some training, and that's one of the things that we talk to Maichu about. To Shiva about, and I think she actually gets that. So,
if I may make a few comments, I don't have much experience with the Hmong population, but I do have extensive experience in being in the role of being a native Portuguese speaker, working with, for example, the Portuguese-speaking community, be that Brazilian, Azorean, or the European Portuguese. I also speak Spanish that I learned along the way. And in residency training, for example, when I would get interpreters, because, maybe it was a mandatory part of having the visit, or there was a different dialect, what happens is there is more of a communication between that interpreter and the patient, because you can't simply translate what the physician is saying. I wish it was that easy. You have to you have to explain the concept, which is no easy task in another language. So when I was in a position of conducting a visit with a patient who spoke Portuguese, for example, and going back to my attending physician and having to put that perspective back in English, it was, kind of similar of the, reverse way of how the communication happens. So the cultural competency that comes with the interpreter, that may be lost in translation back to us.
Yeah.
Because it's just one arm of the equation.
Yeah, absolutely.
And then,
Yeah.
vice versa.
And you know what's great about that is you're saying something, and that's, again, a good interpreter would say, I need to stop for a minute because so let's say I'm an interpreter, in my culture there isn't a concept of cancer. So I'm going to take about a minute and a half. This is what I usually tell patients. This is what it is, and this is how I explain it. Is that okay with you, doctor? The doctor say yes. And then they go ahead and do it. But you know what's going on. Unfortunately, what happens sometimes in bad interpretation is there's this black box in the room of communication. You have no idea what's going on. And it's really important to ask the interpreter. This should be very open to both the patient and to me, because it's pretty freaky for the patient, too, if they don't know what's going on, and you and the interpreter are having a discussion, and they're like, what are these people talking about? So and they're in a much more vulnerable situation than you are as the physician, obviously. So that's also really important. Jim. Thank you.
Really great illustration.
Jim, we have new technology here.
Oh, yeah. Thank you.
Actually, my question was going to be about technology. So moving, which I'm not a great example of, but we're moving very quickly to a digital realm, which is probably going to be only more of a barrier. Even with interpretation skills, when I'm at an outside, not at the center, at UW-HC, it's almost always on a tablet, which in terms of interpretation skills. So when I walk in the room, the interpreter, we've kind of turned that on, and there's right away a barrier. They've had no time to develop rapport.
Right.
And so any work right now, and we can only see further because of cost constraints and logistics, that's going to be the wave of the future. Translation services being really digitally or telecommunicated.
Yeah.
Any work on that, how they can make that a little bit more culturally sensitive?
Yeah, so you're talking about using the iPad. So there's this new technology, which is video interpreting. First of all, I would say, I don't know what people's experiences in the room, but I like video interpreting a lot better than telephonic interpreting. The reason why is because it's more like they're in the room than on the telephone. So that's good. And they can also see what's going on. You know, there's this, I personally believe, but it's really, I'll just say it's totally non-scientific, it's a personal belief, that in-person interpretation is better than any other type of interpretation. But there needs to be more evidence for that. And actually, there's some of us actually working on grants to actually look at some of those things, comparing these different types of interpretation. There hasn't been enough done on it. But I do like video because of that reason. They can get the visual clues of what's going on. Because just like physicians, interpreters work off that too. We work off the visual clues of what's happening in the room. So that's really good. The other reason why other way in which video interpreting can be really positive is a lot of times your face-to-face interpreters in small enclaves of linguistic communities, let's say the Hmong and Madison, or I was in Maine recently, and they were talking about they have a very small Somali group there. And the person who's an interpreter is usually the most highest educated, seen as a leader in that community. They often might have had a leadership community, and they actually act as a leader in their community, but then you're in an encounter with them, and then here's this weird power differential with the interpreter too, and so they might be concerned about revealing certain things or having certain conversations because they're worried about getting back to the community or someone they really respect or an elder actually hearing what's going on. So what's great about video interpreting is that you can get someone from one of those rare languages in different places in the country and they don't know that community. The other way it can be good is if you have a male interpreter and a woman's from a culture in which she cannot be uncovered or actually be seen by another man. You can actually have the video and turn it off phone's also good for that. So there's different ways in which it's positive, but there are issues. One of the things that I've heard is that there's a lot of, here particularly, is that there's a lot of technological issues with it, so sometimes it doesn't always go very smoothly, and that's a big issue. Then it interrupts the conversation, but I think it's a really good question. I think one of the things we're not looking enough at is what's the experience of the physician and the patient in these encounters. A lot of times, and with these different technologies, a lot of times healthcare systems go, well, it's the cheaper way, we're going to do it. So I think as a physician giving feedback as to what your experience is, I think would also be really important to thinking about changing things. But it's better than no interpretation, which happens in a lot of places. So it's not perfect, but there was another question.
I actually have
Two questions, okay.
comment more on the privacy issues involved with having a family member do the interpretation, because my personal bias is that is an effective interpretation, but I know there's privacy issues. I'm not sure that the privacy issues in the Western culture should be applied to other cultural privacy issues. That's my first question. And my second question is there any way you can charge more or have recognized how much more time it takes when you're in a visit with an interpreter and compared to an English-speaking patient?
Yeah. So I'll start with the second question. No, there's no way to be able to charge more for actually working with an interpreter. And actually there's, in most places in the country, there's no reimbursement for interpreter services. That's one of the issues with actually providing good interpreter services. But one thing I will say is that they have done studies that are basically time studies where they actually look at how much time someone spends in an interpreted encounter versus a non-interpreted encounter. And it turns out that if someone's experienced and has training to how to work well with an interpreter and knows the patient, it actually doesn't take any longer. I know that's surprising. That's not what most people's experience is. If you're untrained or don't do it very often, it does take longer. This first question is, what are the privacy issues around having a family member as an interpreter? So, English-speaking patients have their patients in the room. There's no problem with that if it's okay with the patient that the family member is there. There are some big issues with using family members as interpreters. There are a couple big issues. Potential problems. There's some really good things about it because often the patient trusts them and really likes them, right? One of the big issues is that, I don't know, someone in the back was talking about doing interpreting in this room. Who else has done any interpreting in this room? One other person. So it's a very high-level cognitive task. It's actually very hard to do, and it's very hard to do well. So if you talk to people who direct interpreter services, people come and say all the time, I'm bilingual. But what they are is they're not bilingual, and actually only 10% of people who come in who test to be interpreters often actually test into being an interpreter, because it's very hard to do. The second thing is, these are even people who actually had instruction in what are the medical terminology in that language. A lot of times when people are bilingual in this country, they grow up speaking it in their home, but they don't know the parts of the body, they don't know how to explain certain things. There's a lot of technical stuff we often talk about, that's on us, but a family member may feel uncomfortable actually not saying, like, I don't really know how to explain this, doctor, to my patient. So there's some real issues with the potential quality of the interpretation. And then when it comes to the confidentiality issue, there's I have tons of anecdotes, and there's some research that bears this out as well, that family members actually have their own agenda in an encounter, and that can play a role too. So that's some of the cautions of working with a family member. A tip of working with a family member is, though, if you're concerned that the family member is maybe having their own agenda, you can say, look, I'm totally happy to have you interpret. I'm going to have the hospital interpreter in the room just so I can better understand what's going on, and that's part of what we ask people to do here. So they can be there, they can say nothing, but they can tell you what happened in the encounter afterwards if you have any concerns. The second thing you can do is give the same tips to a family member that you could give to any other interpreter, which is like, if you don't understand something I'm explaining or know how to interpret it, please stop me and tell me. I'm going to help think about it in a different way. I'll help you put it in simpler language. There's all sorts of ways that you can help a family member do interpretation better, if that's what the person's preference is. And then and you also brought up this issue of like sometimes in collectivist cultures there's a preference for the family member. What I've actually found is that if you ask people their opinion, if you ask them for their preference, they'd actually rather have a hospital interpreter. They don't want to put that burden on their family member. I think they also have some concerns about what information is coming back to them. So that's a long answer to that question. I think we have yes.
These are very interesting studies, of course. I'm wondering, are you planning to extend such studies or contrasts and comparisons with other groups such as our increasing Arabic-speaking population?
That's a really good question. So one of the things I'll say that's actually pretty unique about our study is a strength, is that most people actually only look at one linguistic group at a time. So I think it's really great that we are able to look at two different groups here. No, that was not a plan, but it's a great idea. But I do think it's really important, because that's the other thing, is everyone thinks, they're limited English proficient. But, as Nizar brought up at the beginning, there are cultural issues that are very different. And you saw the demographics of these two groups are so different and how we need to communicate with them. So thinking about the unique needs of each population, I think, is a really important point, and I appreciate you bringing that up.
Liz, before we close, let me just ask a question. Medical care more and more is a team effort.
Yeah.
And so much of a medical visit occurs with the doctor and the patient, but beyond that, their intake, the work with the MA, follow up with the nurse perhaps.
Right.
Have you studied those interactions, how culturally competent we are, and how are we doing?
We did not study. That was not part of our study. Did anyone? No, I don't think they didn't talk about the staff at all in this group, but I think that that's really important. I can tell you from some of my previous work looking at institutional trust is that how people are greeted and how they feel in the system actually plays a huge role in their willingness to put trust in the doctors in that institution. So that is a really, really important point.
I just think of our avatar scores, and some of it is on us and some of it is on
Absolutely.
the entire environment of care.
Absolutely.
Well, we have to close. I want to thank Dr. Jacobs for just now.
Thank you.